Hello, you're tuned to Pregnancy, Birth and Beyond, contemporary conversations where stories, science, traditions and new ideas meet. Pregnancy, Birth and Beyond. It's about family, connected parenting, celebrating your amazing body, connection with your community and finding your truth. Our show is coming to you from the studios of Bay FM in Byron Bay and is broadcasting across Australia on the Community Radio Network and globally via our podcast at pbbmedia.org.
Hello over there, PBB friends and listeners. It's Anna Lee. Welcome to this very dope episode where I caught up with pioneer Californian obstetrician Dr. Stuart Fishbein. It's a bit of a long form interview today. I hope you enjoyed as much as I did. Grab a cup of tea, grab your washing to fold, and sink your teeth in. It's a great interview.
And then the baby starts to not tolerate labor very well, and they end up doing a C-section, which they call an emergency, and they saved your baby, and isn't that great? And how could you possibly have a home birth? Because what if this happened at home? Because what would you do? Of course, this stuff doesn't happen at home because we don't meddle with Mother Nature that way, and they make it sound as if they've done something great when actually they've caused a problem, and then they treat the problem, and then they pat themselves on the back for treating the problem without thinking about the fact that maybe there is something about epidurals that is negative, but you never hear consenting about an epidural from an anesthesiologist or an OB or a nurse that's negative about an epidural, other than, oh, you might get a little headache or you might get a black and blue mark on your back, that sort of thing. But they never talk about it in a deeper sense, that you're altering the whole process that nature has designed by numbing the mother.
Welcome. Thank you, Dr. Stuart, for joining us for the Pregnancy, Birth and Beyond show. So super excited about chatting with you today.
Happy to be here.
Awesome. Tell us first maybe where are you in the world? Where are you hailing from?
I'm in Los Angeles. Right now, we just had a bad heat wave. It seems to have passed a little bit, but we have lots of fires and smoke, and it's a crazy place right now. But I've been in Los Angeles for a long time. But I work all over Southern California because I'm pretty much the only person offering the choices that I am. So yesterday we had a schedule, you and I were scheduled, and I had to cancel because I was assisting twins down in San Diego.
Amazing.
And I have another set of twins due up in Santa Barbara, and then I've had two other breaches on the same day. We had 3 moms and 4 babies in 25 hours, in a 25-hour span. So
wow,
it was a busy run. So I'm a home birth obstetrician, and I help women have choices at home that they're very limited in, or they don't have any choices in the hospital setting. So that's what I do.
It's amazing. It's actually incredible, this work that you're doing. Not many obstetricians actually do home births. And then on top of that, not many of them are very kind of committed to the normal physiology of childbirth as you are. I know you had such incredible training. You trained at Cedars-Sinai and then also at one of LA's busiest hospitals, actually, or one of your country's busiest, one of the United States' busiest hospitals. How was that in terms of, how did that add to your training, and at what point did you get interested in the normal physiology of childbirth?
Yeah, I trained in the early 80s. I was a resident here in Los Angeles at Cedars-Sinai. And as part of our collaboration with USC at the time, we went to Women's Hospital downtown in East LA. And at that time, it was the busiest hospital in the country. They were doing about 22,000 births a year there. If you break that down, that's about 65 babies a day. And we had a small group of residents that were taking care of all these women. And so we got really good training. And it was a different era. You can't do now what we could do then. I mean, there were less rules. And so, we had breaches laboring in the hallway, and we had, so we did breaches as part of, we considered it normal. As a matter of fact, they were doing research at the time at USC on breech delivery. And we did twins and how to reach up and pull out a second twin. And we learned forceps deliveries. And so it was a really great training for what I would consider the core skills of being an obstetrician. And one of my biggest complaints now is the fact that residency programs have gotten rid of things like breech and vaginal twin delivery with a breech, or even with 2 head down babies. And they don't teach forceps anymore. And so the core skills that make my profession unique are being lost as my generation, and maybe people a few years younger than me, begin to retire. There won't be anybody left out there other in the medical world. So the midwifery world is left to carry the torch for these specific skills. And it's funny because it's the medical world that then regulates the midwifery world and prevents them from doing what the medical world won't teach anymore. And it's not because it's unsafe. And the safety thing is always used as a canard, because to get people to do what you want them to do. But ultimately, the decision on safety should not belong to any institution or insurance company or any even medical practice. It should belong to the individual woman and her family and their life experiences. And she should have we should have respect for shared decision making and autonomy in decision making. And we should be able to individualize our care. But what medicine has done is it's really put people into an algorithm, and ultimately the algorithm is there to protect the institution or the system, not necessarily the individual patient or even the individual practitioner. There's a thing in the world called confirmation bias, and we see it all the time in politics and in our everyday lives, where people will hear information, and if it confirms a belief or it supports the foundation by which they practice their lives on, then they adopt it right away. And if it doesn't, then they ignore it or they ridicule it. And so what happened was that the trend was already going down about vaginal breech delivery prior to the 2000 term breech trial. And this paper came out that initially said that it's much better to deliver babies by cesarean. It's much safer. But it turned out that the paper was completely flawed. And many papers that come out since, almost most papers that have come out since on breech delivery, have found that the differences are much, much smaller than that, or none at all, and that breech delivery should be something that is taught. And even the Royal College of OBGYN, the American College of OBGYN, support properly selected term breech delivery. They support it in a hospital setting, which I understand that. They don't support anything in the home birth setting, so I wouldn't expect them to support breech in the home birth setting. But they say that with a skilled practitioner, but they say because of diminishing experience or expertise, that C-section will be the delivery method of choice. And it's like, well, wait a minute. You're saying that it's safe, but nobody knows how to do it anymore because your people are not teaching it. I mean, talk about catch-22s and Orwellian stuff. Like you said before, the risk aversion is leading to more risk than if they would have just left things as they were.
Yeah, absolutely. It's actually mind-boggling when you think about it. And I wonder, having looked into it quite a lot over the past few years, I wonder if it's often, like you're saying, the confirmation bias. It really our attitudes towards what we do in our practice are often very much so based in our values and in culture rather than in research or evidence or what other people want for their own care and stuff like that. And so this is why these conversations are so relevant and important.
The whole maternity care system in my country, and I'm assuming most Western countries, is based on economics, expediency, and medical legal concerns. So the decisions are made for those reasons without considering the fact that every time you mess with Mother Nature or you institute some policy, there is going to be a downstream ripple effect that's going to cause a problem. And I'll give you an example would be, because I always think examples are important when you're just throwing out generalizations. But the C-section rate in our countries in 1970 or so was about 5%. And then they instituted continuous fetal monitoring, and they instituted the Friedman curve, and where all women, of course, all first-time moms should dilate at exactly the same rate. And that seemed sensible to people. I don't know how that seemed sensible to people, that all women should dilate at the same rate and follow a curve.
I'm pretty sure that Friedman curve was based on a study with 100 women. And
yes,
one person alone observing that and making their own conclusions. And now millions of women around the world that give birth every day, it's 250 babies are born every minute. And so many people now use that 1 centimeter per hour based on one study from one person who observed 100 women. And the impact of that is it's immeasurable, incalculable.
And not to mention that, how do you know if a woman's dilating 1 centimeter an hour? You have to do a vaginal exam on her every hour or two.
Yeah.
And we know that causes problems. All right.
Absolutely. It's absolutely causing problems from so many perspectives in terms of the woman. You know, I always it's a bit of a gross analogy, but I always tell people, if you're on the toilet trying to do a poo and somebody comes in and sticks their finger up your bum, what's going to happen to that sphincter? It's going to immediately shut up, you know, and close in and suck everything back up. And people don't realize that the body that's how it works. It's a very complex mechanism that's working. A million things are happening in every moment, and if somebody's coming in and sticking their fingers up a woman's vagina to check every hour what's happening, it's not conducive with the body opening up and doing its thing, what it needs to be doing. And so yeah, it's that double-edged sword.
And Annalie, the other thing too is that things like this are adopted immediately. When something fits the system that they want to, they adopt it immediately. And then even when they realize that it's wrong or that it's not the only way to do it, trying to get rid of it is almost impossible. The same thing's true with continuous fetal monitoring, which is the other thing that's caused, because the C-section rate now in my country is over 30%. It's probably the same in your country. So
yeah, 34% here.
Okay, so let's just do it. Let's just do a simple thing. The C-section rate has risen in our countries about 500% in 50 years. All right, from 5% to 30+%. All right. By that token, we should have far greater safety profiles, right? Because obviously you're doing C-sections for safety, because that's why we do them. That's why we do all these things. But we have found that the rate of cerebral palsy, the rate of hypoxic ischemic encephalopathy, the rate of neonatal death has not really changed at all. If anything, it might have gone up a little bit in my country. We have a 600 or 500% increase in the cesarean section with nothing to show for it. Not to mention a couple other things, not to mention that down the road, we're already finding that babies born by cesarean section, especially ones that are pre-labor, that are scheduled without labor, where the baby didn't choose its birthday, those babies have a higher rates of things like childhood asthma and adult onset diabetes and autoimmune disorders. And the microbiome is affected. Okay. But another thing that's really crazy about this is, even if you think about, we talked a little bit about confirmation bias, but let's talk about its sister, which is called cognitive dissonance. All right. Because the World Health Organization, which many of us right now are not too happy with, not in my country anyway, thinks that the C-section rate in Western countries should be 10 to 15%. So let's just say 15% because it's easy math. All right. That means it should be half of what it is right now in your country and half of what it is in my country. Well, in my country, we're doing about 1.4 million C-sections every year, which means there's 700,000 of them that are unnecessary. If there were 700,000 unnecessary surgeries being done on your knee or your breast or something else, there'd be an outcry to the heavens. But when it happens for babies, nobody says a peep. But here's the crazy thing. If we think that half the C-sections being done are unnecessary, here's the cognitive dissonance, because no doctor goes home at night and says to their spouse, hey, honey, guess what? I did 3 unnecessary C-sections today. All right. So every C-section that a doctor does, they think is necessary, yet half of them are unnecessary. That doesn't meld well. So they have to come up with these ideas. And what happens is they adopt the thing like fetal monitoring, they adopt the thing like the Friedman curve, or now the latest thing is, if you keep up on this stuff, obviously I can tell, is this ARRIVE trial, where the latest thing in the Green Journal, there was an article that talked about how it's obviously settled now that inducing at 39 weeks is a good thing to do. Not everyone's going to want to do it, but we know it's a good thing to do. All right. We're going to find out 5 years from now or 10 years from now that that's crazy. Yeah. When you mess with Mother Nature, when you intervene with something, there's always going to be problems downstream. All right. Nature doesn't do things for no reason. All right. It does things for a reason. Now, does it always do it right? No, of course not. And do you want to avoid that stillbirth? Of course you do. All right. But by inducing people and assuming that they're going to have a lower C-section rate because you're inducing them, but inducing them early isn't going to lead to more babies having other problems or in the NICU or we don't know, we don't even know what the effect of artificial Pitocin is, or the use of epidurals. I mean, I have a really strong feeling about epidural anesthesia and the labor process that very few other people I've ever heard talk about it. One other midwife I know has really kind of planted the seed in my mind. People think that epidurals are just what's like labor's a toothache, and that you shouldn't have any pain in labor. But if discomfort in labor isn't important, then why did nature not get rid of it? Why did it continue?
Pain is such a it's such a big topic. I think a lot of people are very pain averse, and it's something that starts very early on, possibly in our birth itself, when we're born kind of numbed out because we've had an epidural ourselves, or some pain relief impacted on us from our mother who's had pain relief, and that's gone into our systems. But then it's perpetuated. When a child falls, it's quickly, oh my God. Or when they've got a fever, it's take this. And when there's pain, it's always outsourcing a solution, that there's something wrong with pain and let's outsource a solution. While as the body's mechanism for letting you know that something's going on, that you need to stop everything that you're doing and pay attention to this thing. We know now a lot of resilience is built through different forms of pain, whether it's psychological or physical or whatever it is. And when we're bypassing that whole process with pain with childbirth, we've got to ask what's going on. But also I've come to really see that we cannot be asking women as they go into labor, or people who are giving birth as they go into labor, oh, you've got to deal with this pain now. If they've spent a whole lifetime in pain management and separating from pain and trying to get away from pain, it has to start at a much earlier time. It's not to say that they can't. I think the body's, brilliant, and some people can just, even with a lifetime of interventions, can come to childbirth and kind of their body will take over if they let it. But at the same time, it's not common for that to happen. And I think education early on is very, very.
It even goes. My whole take on this is even sort of. It even dives deeper into it, and let me explain if I can. There's a brilliant American economist named Tom Sowell who came up with the idea of what he called stage one thinking, which is putting something into effect because it sounds good or feels good, but not looking at deeply into what will happen next or down the road. And a lot of what we do in obstetrics is stage one thinking. All right. It's like, okay, we're going to use fetal monitors and we'll get rid of cerebral palsy. No, all we did was raise the C-section rate by 500%. All right. They didn't think about it. But here's the thing with the discomfort that I was talking about, which is slightly different than where you went. All right. Is that my original question was, and if people would just step back for a second and just listen, this would be really interesting. I mean, I just think that you start to see things in a different way. But if pain, nature doesn't do things for no reason. And so if pain in labor wasn't of some value, it would probably get rid of it, because it doesn't behoove a mammal in the wild to be moaning or to be uncomfortable, because it's more likely to be caught by a predator in that case. So you would think that quieter, non-painful labors would be genetically beneficial. But labor pain has persisted in all mammals. So there may be some. So here's what I think is happening. When you have a contraction every 3 minutes, or a surge, or whatever you want to call it, your body puts out neurotransmitters like adrenaline, which helps to space out your contractions a little bit, puts out cortisol, puts out endorphins, maybe, and then oxytocin, of course, is your bonding hormone. And they help you cope with that contraction and get you ready for the next contraction. All right. You give an epidural and you don't have to deal with that anymore, and it's all gone. But every time you're having a contraction, your baby's also experiencing something it's never experienced before. Its world is changing. The water has broken. The baby's head is getting squeezed. So every 3 minutes, it's getting a waft of mom's hormones. The adrenaline, the cortisol, the endorphins are crossing the placenta and maybe helping the baby cope with its transition into its new life. The minute a mom gets an epidural, mom is comfortable, but baby is still undergoing the same stresses, and now it doesn't have its mom anymore. Right? I know that sounds like romantic or weird, but it's been cut off from its mother. And therefore, how often do you hear about women who they get an epidural, then they get Pitocin because it spaces out their contractions. They get Pitocin, and then the Pitocin makes contractions every 2 minutes, and then the baby starts to not tolerate labor very well, and they end up doing a C-section, which they call an emergency, and they saved your baby, and isn't that great? And how could you possibly have a home birth? Because what if this happened at home? Because what would you do? Of course, this stuff doesn't happen at home because we don't meddle with Mother Nature that way. And they make it sound as if they've done something great when actually they've caused a problem, and then they treat the problem, and then they pat themselves on the back for treating the problem without thinking about the fact that maybe there is something about epidurals that is negative. But you never hear consenting about an epidural from an anesthesiologist or an OB or a nurse that's negative about an epidural, other than, oh, you might get a little headache or you might get a black and blue mark on your back, that sort of thing. But they never talk about it in a deeper sense, that you're altering the whole process that nature has designed by numbing the mother. Because obstetrics doesn't think of mother-baby as a unit, all right? The baby belongs to the pediatric department as soon as it's out. Where in the midwifery model, mother-baby are a unit and they stay together and they belong to the midwife and the team, and that's the way it works. And so we think of it differently. An obstetrician's job, if you think about it just purely on a technical standpoint, is to get a breathing baby into the bassinet. Once it's in the bassinet, it's not the obstetrician's purview anymore. It belongs to the pediatric department, so they'll deal with it. But I just want that baby out. I know that that's very callous and basic and stuff, but that is the algorithm by which doctors are trained. That's how we're trained, all right? To look at pregnancy as a problem, or pregnancy, as you've heard it before, as a disease or an illness, as opposed to pregnancy as wellness and a natural process that occasionally goes awry. That's a big difference. So when I talk about epidurals and like that, some people, they shake their heads and they say, well, you're out of your mind. And other people go, I never really thought of it that way. And you're right. I'm comfortable, but my baby now is not comfortable, and I'm not helping my baby anymore. Maybe.
I think that's a very, first of all, you're speaking as somebody who's attended thousands of births over a 30-year career, and you've experienced childbirth and maternity care and obstetric care within various different settings, from the biggest hospitals and busiest maternity wards to quiet home births, to all the different types of births. So I think it's fair enough for you to draw some kind of conclusion from your work about, not even a conclusion, but to ask a fair question. What is going on here? And to have that hat on, the investigative hat on, or the inquisitive hat on, to say, are we doing the right thing? That's very, very much fair enough. And secondly, when you said that, I had goosebumps. I was like, yes, this is absolutely true. And for me, that feels very real and very true, that we're kind of disconnecting the mother from its baby in some way. And it sounds very difficult because a lot of people will choose epidural for pain relief. And I think there is an issue in maternity care and in the birthing world, and just in general in motherhood, when we're making statements like that, or making even just inquiries. People can get very deeply personally offended because they chose an epidural for pain relief because they couldn't handle the pain. And they think that this kind of a conversation is directly pointing a finger at them and saying, look what you did, that was not good. And for women and mothers and people who are birthing, for me, as somebody who's been interviewing people for years and years and having this discussion again and again from different angles and looking into it, I think it's more important than ever to be able to have these open, inquisitive, inquiry-based conversations from people who know what they're talking about, and with people who know what they're talking about. Because otherwise we're going to get further and further deeply into this space where there's a lot of conflicting advice, and we can't, and which makes it even harder for the person experiencing the care and the people giving the care. It creates more separation, more normalization of trauma, more cognitive dissonance, as you say. And it's not about the personal pointing of the finger and
no, it's not.
At all.
I'm pointing the finger at the academic branch of my profession, because I do believe that they're very obtuse and not considering the things that I'm saying, and having a model which then funnels people down a path that leads them toward all these interventions. For instance, the other question will be, well, why do 80 to 90% of women in the hospital have an epidural? All right. What percentage of women at home have an epidural?
0, is it?
0. Right. Okay. How do they do that? Okay. Yeah. Well, because at home, we allow them to deal with discomfort in other ways. All right. They can move. They can get a massage. They can get a rebozo. They can get in the shower. They can get in the tub. They can rock on a ball. They can get on all fours. They can, you have ways of dealing with discomfort, which, comes in a surge, lasts about 30 to 40 seconds, then goes back down again. All right. If you can move during those things, if you can do things for that, then it's fine. But if you're stuck in bed with little belts on your belly and all your choices are no medicine or laying in bed with no medicine or laying in bed with medicine, well, yeah, you pick medicine. But the system isn't designed to let women labor as nature intended. You would never do this is one of my famous memes, but you would never do to another mammal what we do to the human female. Interrupting them, you talked about, people standing around and sticking their fingers in you or staring at you or interrupting you or asking you silly questions or limiting your mobility or taking away your food and limiting you to some water and in an environment where there's lights on, it's not going to, you would never, no other mammal would labor that. They would get up and they would run away. And labor would stop because they put out adrenaline until they found a safe place. And then they'd go back into labor because nature knows that it's not good for the reproduction of the species to give birth in a situation that's anxiety provoking or dangerous. So the fact that, we have a large percentage of women who go to the hospital still deliver vaginally, that just is a testament to the system. But the idea that we limit the people's ability to deal with discomfort, so we offer them only an epidural or maybe some Stadol or fentanyl or something, that's all we offer them. Let them get up, let them walk around, let them get in the shower. They're worried about liability. Well, now the patient's in the hospital. If there's something that goes wrong, it's going to be our fault. All right. But I know that, again, I don't want to sound too harsh to the system that I came from, but you're right. I've seen it both ways. I've seen the success rates, the satisfaction rates, the C-section rates, and they're significantly different in similar cohorts of women if they're at home or in a birth center versus the hospital. All right. And it's the way they're cared for. It's the model by which they're cared for that makes the difference. It's a huge difference. The hospital, look at the newborn intensive care unit of hospitals, besides being a money-making proposition, is filled with babies who came to the hospital. I mean, not filled, but there's plenty of babies in there that came to the hospital that were perfectly normal. And somehow during the process of hospital birthing, they ended up in the NICU. All right. So when they point fingers at the 1% of us that are doing home birthing and say, oh, there was a bad outcome at home, or some movie star had a bad outcome, and that's all over the, Google, and it's all over the place, stuff like that. Yeah, well, yeah, but you know what? For every one of those, there's hundreds, if not thousands, that happen in the hospital, and you don't hear about them. Okay. And two, the problem with our obstetrical care, the maternal and neonatal morbidity, the high C-section rate is not because 1% of women are having birth at home. Let's talk about the 99% that are birthing in the system in the hospital, where they're not allowed to labor as mammals are designed to labor, which is quiet, safe, and unobserved, as my colleague Sarah Buckley likes to say, your countrymen.
Yeah, absolutely.
Right.
Yeah, that's such a powerful argument that we're as a not-for-profit community-run media and journalism organization look at all of the time. We look at how there's so much trauma and bad outcomes in hospitals that are never reported yet. The singular report from Homebirth, for example, can cause countrywide drama for years to come. And it's really important to note that it's the perception really that we're talking about here. It's not actually the facts. Look, countries like Holland have a third of babies are born at home. 1/3 of all babies in Holland are born at home. So it's just a matter. And in Brazil, in some of the private hospitals, you've got an 85% cesarean rate. There's some hospitals that I've heard of that have a 95% cesarean rate in private hospital in Brazil. And so that just goes to show, if you look at that versus the 30% versus, you know, the 1% of home birth in the US and the 0.5% of home birth here in Australia at the moment, we're not talking about facts or evidence or safety or anything. We're talking about perception of danger, or perception of risk, or perception of what is safe and what isn't safe. And we're not actually talking about the evidence. And I think this is something that we're constantly inquiring about, how people's values and ideas and beliefs and perceptions about certain things really impact what they think is real and true. And within maternity care and childbirth, it's a very pertinent question. It's a very alive question, because, you know, some areas you can just kind of move along with it, but this is something that is impacting people at the beginning of their life, when they're creating those imprints for their not only their health and well-being with themselves, but their health and well-being with their relationships with their care provider, with their family unit, with their communities and everything. And this is a very important conversation to be having. And it's just really wonderful to be hearing this from you, from your end. And I feel like you're a beacon of hope over there in terms of carrying this torch. But how many friends, obstetric friends, I wonder, do you have that are kind of keen with the same kind of mindset and doing the same kind of work do you have over there in the US?
I don't know anybody that's doing the same thing that I'm doing. I knew a couple, and they both retired. Mm-hmm. No young person. Well, actually, there is recently moving into the Riverside area here, which is in the eastern part of it's east of LA. A woman just finished her residency program and wants to start a home birth practice. You know, it's interesting. I mean, I don't know what her training is like as far as breeches or twins, but I'm thrilled. I think, first of all, there's a lot more satisfaction for what I do. I think, because again, I have the unique experience, as you said earlier, that I have worked in both worlds. I spent 28 years in the hospital setting before leaving the hospital. And I've been now in my 11th year of doing community-based birthing. And that, you know, just the whole idea that there's other people that are going to do this, it's very unlikely, because what happens in training programs now is doctors are trained to work within the system. And it takes a very unique person to want to work without the system. One of the things when I give my talks, or even when I do something online, one of the things I say, if there's a doctor, or if there's a resident or a medical student listening who wants to go into obstetrics, they must demand, when they are in their training programs, to learn these skills like breeches and forceps and things, because if they really want to be a true obstetrician, these are the skills that make you unique. And if you come out of your training program not knowing how to do it, you're never going to really do it in private practice or working for a group practice. Because even if you might want to try, your partners won't want you to try. They won't let you. There'd be a lot of pressure on you to not do it. So you have to learn it when you're in training, and when they're not, and it's not being taught. So there are very few people doing what I'm doing. Midwives do what I do, but they're restricted by laws lobbied for by physician groups to prevent them from doing things like breeches. Midwives, not all midwives, but certainly more midwives know how to do breech delivery and twin delivery and feel more confident and comfortable with it than doctors do. And yet constantly the laws in states are in my country are being set so that midwives can't do these things. And then I said earlier, the hospitals aren't offering them, so the skills are disappearing. And women who have a primate breech and who aren't even given a choice to, consult with somebody like me or one or two other guys in my whole LA area who do hospital-based breech delivery, and they're told that it's dangerous and the head will get stuck and you really should have a C-section, and they schedule their C-section, and then they find out later on that maybe there was an option. That's horrible. But not only that, but in the subsequent pregnancy, there's going to be a small percentage of those women that are going to have a uterine rupture or a placenta accreta because they had a cesarean section in their first baby that might have been avoided. And I will tell you that although my numbers don't reach statistical significance, Annalie, my C-section rate for a multiparous woman with a breech baby, or my success rate, is 100%. Now, it won't be at some point, there won't be, and for primates, it's 80%. So over 80% of women who come to me with a breech baby, even first-time moms, will have a vaginal delivery at home. All right. The chance of you having a vaginal breech delivery in the hospital is about 1%. And it's only if you show up basically with the baby like falling out. And then they might catch the baby.
They might catch the baby.
But other than that, they actually will push the baby back up inside and do a C-section and then deliver the baby breech through your C-section scar instead of through your vagina. And that's what they're trained to do. And they think that this is the norm. They think that this is good medicine. And because it is repeated over and over again, and because it's what's taught in residency program, people assume that that's the safest route. But I'm telling you, it's not the safest route. It's not. And the world literature doesn't support doing cesarean sections on all women. I personally think that a woman who's already had some vaginal deliveries, who has a breech baby, if they're not offered a vaginal delivery with somebody who knows what they're doing, and they're told they have to have a C-section, that to me is medical negligence. And in my country should be something that's subject to being sued for, because the success rate is astronomically high. And if you don't know how to do it, you have two choices. You can refer them to somebody who does, or you can take a few months off and go to Frankfurt, Germany, or go see Andrew Bissett's and spend some time at the, what's it called, the Queen's Hospital, King's Hospital, whatever it's called, in Sydney.
The Royal Women's, yeah.
What's it called?
Royal Women's.
Royal Women's.
Yeah.
I knew it was something royal, yeah.
Yes,
Royal Women's.
Royal.
and spend some time watching from people like Andrew or Frank Lewin in Germany. You know, there's a Mark Glazerman's in Israel, but all of us are getting old. You know, I mean, there are no real young people who are these breech experts. So when we retire, the skill will be in the hands of basically lay midwives and a few countries that still allow it, but which aren't very many anymore.
Yeah, and I think, God, I mean, having studied history and and just how humans organize over centuries and decades, the danger of losing skills is one, again, it's astronomical, because it's it's nearly impossible to reinstate lost skills in such a way, because there's no one to show you how to do things. There's so much you can learn from a book. It's actually learning in the room with the person and troubleshooting things again and again and again, which give you the skill. We're not talking about just knowing or reading something. We're talking about the skill of being able to problem solve within the moment of an actual real live situation. And that's a very different thing from just having some information in a book. And so, yeah, I feel the weight as a consumer, as a person who accesses maternity care and a person who advocates for other families and women and people who give birth who access maternity healthcare services. To me, this is a massive weight in terms of a big concern that we have, that clinicians are losing these very vital and important skills. And someone might say, well, you know, we've got C-section instead. But again, it comes back to that stage one thinking, where you're not thinking about the whole picture. And there's a lot of risk within C-section. I think ones that we haven't even spoken about today, like what are the impacts from cesarean section on our evolution as a species as well. If a third of babies around the world, let's say just, you know, I don't know what the statistics are for worldwide, but if let's say a third of human beings are being born not through the normal way that the body was designed to do it, what does that say about us as a species? You know, and where are we going within that?
Yeah, and I mean, it's interesting. If you think worldwide, you think of, you know, other countries, like C-section in Western countries is a relatively safe operation. Certainly it carries risks and it carries morbidity and carries risk for future pregnancies. But if you're losing the skills of breech delivery, you're also losing the skills of breech delivery in third world countries. And in third world countries, you have much higher maternal mortality with cesarean section. And so if you were to section all breeches, okay, while you might save a certain number of babies in the first pregnancy, you might lose an equal number of mothers from the surgery. So again, that's called stage 2 thinking. It's like, well, if we ban breech teaching, you know, in Los Angeles, well, okay, so will everybody have a C-section? But what about Malawi or Tanzania or a country that doesn't have the systems that we have in place here, where there's a hospital essentially every 6 minutes from another hospital, with modern ORs and antiseptic techniques and things like that, where many other countries you don't have those sorts of things. Women have to be relocated when they get close to term to live in dormitories so they can have birth in a hospital setting, or they have to walk 7 miles to a prenatal visit. It's not all the same. The skill needs to be sought, because 3 to 4% of babies at term are going to present in breech, and one out of every 30 babies or 33 pregnancies is going to have twins. And if all we can do is section them, and as you said, we don't know what the downstream consequences of that going to be on our evolution, we're not offering things. I mean, that nature didn't design this system to be altered in this way. It really didn't. And again, it gets back to my initial statement that the whole system is where the problem is, because good people go into in medicine. Caring people go into medicine. All right. Somewhere along the line, you get indoctrinated into a way of thinking that takes you away from the idea that birth is a natural process and birth is normal. And you get into this whole idea of, oh my God, and everybody's nervous, and you're taking women out of where they feel safest, which is in their home or their bedroom, and you're putting them in a car and driving them to an ER, where they have to go to a triage area, and they have to sign in and pee in a cup and put on a gown and put monitors on, and they're asked silly questions that don't mean anything, like how many stairs do you have in your house while she's contracting every 3 minutes. What's the point of asking that question? Why do we even care? Well, because we have a computer screen that has questions on it that have to be filled out in order for you to get a wristband. And if we don't get a wristband for you to get admitted, then we can't draw your blood. And if we can't draw your blood, then we can't give you an epidural. And then we can't, do all the things that we need to do to end up getting your baby delivered by cesarean section and transferred to the NICU for a day under observation. So I know that that's hyperbolic, but sometimes you need to push really far over here to get people to come toward you a little bit. I'm not trying to, as you said, I'm not trying to guilt anybody in particular. All right. I just think that people need to think about it in a different way. They need to ask questions. And ultimately they need to think about how they want what do they want for their birth? Everybody plans their wedding in depth. They spend a lot of money on it. But when it comes to the birth, you take out your insurance card or your HMO card or whatever it is in our country, your country, and you go to the same person that's been doing your pap smear for 10 years, and you don't know anything about them, and you don't know anything about it, and you just go in, and you go in every 4 weeks, and then every 2 weeks, and then every week, and then they tell you you come into labor, and you go into labor, and you have a nurse there you've never met before, and you finally begin to like her, but then at 7 o'clock in the morning, she goes home, and then the doctor that you've been seeing through the whole pregnancy isn't on call that day, so some doctor you've never met before is going to take care and deliver your baby, and we wonder why any other mammal would run to the hills from that sort of scenario. All right. I'm sorry I got all in a frenzy there, but I do that on purpose, because that's sort of how the system just builds upon itself and leads to all these interventions.
I'm with you 100% with this. And I love this way of speaking, actually. I think it's very important. I think looking at what we're looking at, facing what we're facing, it's not only fair that this kind of way of speaking has to exist. We're looking at if we're looking at 95 cesarean section rate in one hospital and a third of babies born at home in another country, we're not having the right conversations. These are the conversations that kind of push you outside of your comfort zone, the ones that make you think, the ones that get you angry and like, no, that's not true. And then you have to go and look it up and you're like, oh, actually, maybe there is something about this. These type of conversations are the ones that actually make change and are part of a bigger picture of us as a humanity, looking at what we're doing and seeing, are we doing the right thing? Are these things that, these processes or ways of organizing that were devised 1,000 years ago or 200 years ago or 50 years ago, even 10 years ago, still working for us? Are they harmful? Have they been successful? Are we looking at all of those kind of things? And I think as a society, we kind of have a tendency to normalize, which is something that's come out a lot through listening to you today. And also it's just constantly something that I'm aware of, how much normalization of trauma that we have, that, people, in order to show up to work, good people with good intentions that have set their life to help others in like studying medicine and showing up in a hospital to work and save lives and help people with their pains and aches and dangerous situations. Those good people, in order to show up every day at work, have to normalize again and again and again, normalize things that they see that may, in that moment, in that first time that they come across them, they might go, oh my God, why did we do that? Or was that necessary? Or, and everyone is normalized around them. And so therefore, this is how this system is created. It's only these type of conversations that can kind of be, that are a little bit jarring, that are a little bit in your face, that can kind of stop that normalization, stop it in its course, even if it's just for a moment, and ask the question, is this okay, what we're doing? And can we be doing this another way? So I'm really appreciative of your way of speaking and the fact that you're very passionate about it, and that you absolutely know what you're talking about, and we need to hear more from people like you.
I mean, I gather pieces of bits of evidence and bits of wisdom from listening to other people, and one of the people that I think has given me some wisdom is a midwife named Augustine Colebrook, and she has a way of saying things where she says we need to break the silos. All right. And what she's talking about is that we need to have some sort of collaborative training early on, where we take nurses and midwives and OBs and osteopaths and allied health professionals and stuff, and have them all working together. And it would really behoove, in my country, it would behoove American residents in OBGYN to spend some time being trained by midwives, and to maybe even do some community-based birthing center or home birthing birth. And it would behoove the midwives in the community to be able to come into the hospital and be allowed to assist in deliveries and teaching and working with the nurses there, so that there's this understanding. And because ideally women are going to choose the birth that they want, and some women are going to choose an out-of-hospital birth. And our obligation to them is to give them the best situation possible. And that means smooth transition from home to hospital, should that be necessary, and an understanding that when they come to the hospital, they're not going to be greeted with like they have three eyes, or that they've abused their baby, or they've been selfish because they wanted to do something different by people at the hospital, but be treated warmly and treated and friendly, and understand that everybody's there for the same purpose. And ideally, if we could break the silos and have communication, where what I'm saying to you right now, I could have a conversation at the next ACOG meeting or our COG meeting, and have a general assembly where you have 300 or 500 OBs there, and we have a panel discussion on the stage where they have somebody like me, it doesn't have to be me, but somebody like me, and a midwife, and an academic OB who thinks what I'm doing or what midwives do is crazy, and another doctor who thinks it's not a bad idea, and have them all on the stage and have a conversation in front of OBs, because I know right now that because of what I'm saying is so uncomfortable and rocks the foundation of so many of my colleagues, that they're, in order to deal with it, they have to deal with it in one of two ways. They either have to ignore the things that I'm saying, or they have to ridicule me and then say that he's that crazy guy in Los Angeles. And, I don't think that I'm crazy. I look at my outcomes. I look at the families that I've touched, and I think that I'm doing good work. I'm not a hero, and I'm not a cowboy. I'm not going to put my career at risk, and I'm not going to put a woman's life or her baby's life at risk by doing things that I don't think are reasonable, evidence-based, and safe. And I understand that not everybody can predict the end outcome. There's going to be bad outcomes in the hospital. There'll be bad outcomes at home. But ultimately, if you include the woman in the process of decision-making, all right, you'll find that there's less likely to be liability. There's more likely to be acceptance, and more likely to be tenderness and sweetness among the things, when an outcome isn't as ideal as you would like it. Because there isn't the hostility, there isn't the adversity, there's a mutual respect between practitioner and client. We call them clients, as you know, because we don't think that they're sick, so we don't like to use the word patient. If we could have that, if you could see, you could see that, and sometimes, and we're seeing improvements here in Los Angeles. There are some hospitals in Los Angeles that are very receptive to taking our transports. that don't look at people cross-eyed. And then you go to sometimes and you get some obtuse physician whose only issue is, how dare you have done this? And they spend 10 minutes berating you while the woman is just sitting there laboring, and they're ignoring the client because they want to berate you and ask you what your medical license number is so they can report you to somebody. And they've forgotten their mission. They're the ones that are actually missing out on the joy of my medicine. I don't know a whole lot of happy hospital-based obstetricians. I mean, maybe they are. Maybe everybody comes to work every day and says, I just love being here. But I don't get that. I never got that impression when I was there, and I don't get that impression from my friends and colleagues now. You asked me earlier how many people do what I do. Not very many. How many support what I do? Well, my local group of physicians who know me, they all think that, they all admire what I'm doing, but they all say the same thing. They said, but I could never do that. I would be too nervous. I wouldn't know what to do. How do you do that without an epidural? How do you do it without an anesthesiologist? How do you do it without a NICU? I mean, it's like, yeah, well,
and that's a very big, just to stop you there, I think that's something that we could pause there for a moment and just lean into that. How do I do that without an epidural? How do I do that without an induction? How do I do this thing without all the things that I have to kind of, let's lean into this. The people who are out there practicing medicine every single day, and they're ill-equipped in terms of meeting the normal physiological process of a complex biological organism that is reproducing. They don't understand it. They're looking at it going, how do I do this thing, like interact with this thing without my epidural, without my induction, without my the continuous fetal monitoring? So, these are things that we need to lean into. This is what's going on in terms of medicine. It's not just in maternity care, it's in the larger picture of medicine as well. How do we deal with these complex living biological organisms that are having an experience, and we're coming at it with all of these things. We're throwing pills at it, we're throwing ideas at it, we're throwing all of these interventions, and we can't kind of meet it where it's at, and I think it's something really big to lean into. And when I say lean in, I mean just stop and pause and go, wow, that's a real thing that's happening. That we're not equipping our care providers with enough support for them to truly meet what it is that they're meeting. So instead, they're kind of trying to manage it and control it and fix it, and in a very narrow-minded kind of way.
No, well said. You said it exactly right. They want to control it. They want to fix it. They're not comfortable in a setting where they, that's outside. Well, again, none of us are real comfortable outside of our comfort zone. So I'm not singling them out, but most people, most residents, as was said beautifully in Ricky Lake's and Abby Epstein's film Business of Being Born, was that when they're training, they never see normal birth, ever. Because if someone is perfectly normal, laboring without an epidural in a labor room in the hospital, the resident isn't there. All right. The resident's called by the nurse when the baby's crowning to catch the baby, write the orders, and then move on to the next task. All right. They never sit and watch a woman labor. They never hear the sounds that a woman makes when they're in labor. They don't. I mean, again, I'm that person. I came out of residency program. I never watched a woman go through her entire labor. And I used to come earlier than most doctors. But even then, if I got there and the nurse got me there too early, I would be frustrated, because now what do I do? So I would go to the doctor's lounge and hang out, watch television, and take a nap or whatever. But I would never sit in the room and just listen. And just watch the amazing things, and watch how a woman, if she's free to move about, her body will move about. She will do, if her hip is bothering her, she'll do a lunge. She'll put her hip up on the bed. She'll roll onto her side. She'll do something, because what she's doing when she's moving is she's responding to what the baby is signaling her inside of her, and she's able to respond to that by doing the things she's doing and the sounds that she makes. And you listen to a woman in labor, and I'm sure you've heard this, or maybe you've had your own children, but the sounds they make get more and more guttural and lionessing, and eventually it's become this grunting sound when that they're starting to feel rectal pressure. And the whole labor, we haven't done a single vaginal exam. but we can tell they're progressing by how they're moving and the sounds they're making and how they withdraw into themselves, and they're not conversing with you anymore or laughing at your jokes, or you should be telling jokes, but you can just tell that they're moving inward. And that's what mammals need to do, because labor is a primitive brain function. And the more you can shut off your cognitive brain, then the more likely it is to function normally, like breathing or respiration or digestion, where you don't think about it all day long. But if you start to think about it, like say you have to give a speech tonight, you may start getting an upset stomach, or you may start to hyperventilate because your cognitive brain is screwing up your primitive brain. And so if we can leave women alone in a setting where they don't have to be interrupted, and they're free to be either observed quietly or not observed at all, we can learn a lot from the labor process and how it works. And that's why it works so well at home. That's why most midwives have a transport rate of between 10 and 20% for primips and almost none for multips. And they have a C-section rate somewhere between 2 and 10%. If you look at midwives, there's certain midwives that have a C-section rate like Ina May or Cynthia Calais in Wisconsin. They have a C-section rate like 2%. And then there are other midwives that maybe 7 or 8%, but it's nowhere around the same percentage it would be if that same low-risk cohort of women was laboring in a hospital, where everything that's happening to them is antithetical to nature's design. So how does a doctor do that? The doctor can't do that in today's training. In your country or my country, they're not going to be able to spend time watching a midwife do her thing in a home birth setting where the doctor's just observing. Because you know what? The residency program won't allow them to do that, because they'll say there's liability there. The midwife doesn't have malpractice insurance. We can't put our resident in that setting. And then you get the risk managers and the lawyers and the businessmen into the mix. And once they get into the mix, well, need I say more?
No. Why did you move from hospital care after 28 years into home care? What happened?
Well, ultimately what happened is that I started a midwifery practice 15 years earlier, about 1995, a collaborative in-hospital-based midwifery practice with a couple of certified nurse midwives. And we were never welcomed in the community. As a matter of fact, they did really underhanded things. It was almost like they were spying on us. They would give us phone calls and pretend to be husbands of patients, asking us questions to see how we'd answer them. In those days, you could find out who called you by hitting star 69 in our country. So you could find it out, and some guy would call and say he's a husband, and then we'd hit star 69 and go, Dr. So-and-so's office. It's like, yeah, right. Okay. So he was checking up on how we answered questions, and they were always suspicious of what we did. And we ended up I took care of the high risk stuff. The midwives took care of the low risk stuff. It was a great collaborative practice, just how it's supposed to be. We were doing breaches and twins and VBACs, and we had a C-section rate of about 7% in our practice. And the next group in the community, and it was a smaller community, so it was like one of those good old boy communities where the doctors who were in there in the hospital for a long time ran the hospital. They were always running the OB committee, and they were making all the rules. And the next closest group had like a 24% C-section rate on the same similar cohort of women. And eventually the anesthesiologists didn't like it because our patients didn't want epidurals, and the pediatricians didn't like it because our patients wanted to go home 6 hours after they delivered. And the hospital had policies in place that said, well, baby can't go home until it's seen by a pediatrician. And a woman delivers at 8 o'clock at night and wants to go home at midnight, and no pediatrician wants to come in. And so they would have to sign out AMA, and there was just a lot of stuff. So it was easier for the hospital, this is my opinion. And again, I wasn't the easiest person to get along with because I had really strong opinions about what we were doing, and we have really good outcomes. But it was easier for them to single me out and do something what we call sham peer review, where they start reviewing me or my midwives for things that they would never review themselves for. If we got a broken clavicle, we would get peer reviewed. If they got a broken clavicle, then nothing would happen. The chairman of my department sectioned a woman for breech whose baby wasn't breech. All right. And nothing happened. But I came one time wearing scrubs from another hospital that I worked at into the labor room of this hospital, and I got written up for it because I was wearing the wrong clothing. Okay. So that's the kind of thing that went on. And eventually they banned the midwives They got rid of their privileges. Then they banned VBAC. Then they banned breech delivery. And it was coming up, I was coming up for reappointment. And the reappointment choices were, they're not going to reappoint me, or I can fight them. So just like they did to the midwives where they didn't reappoint them, or they took away their privileges. You can fight a hospital, but as an individual, they're big and you're small. It's an administrative process where you have very little chance of winning. And even if you do, it's going to cost you a fortune. And then you're going to win the right to stay at a hospital that's going to continue to be hostile toward you. So I had some really good advisors and some local midwives and stuff. They said, why don't you come do some home births? Because I had been backing midwives also, taking their transports for 25 years. And I said, my first thing, I was reluctant, even after doing that for 25 years, I was reluctant to go to a home birth, because I said, well, how do I do that without an epidural? How do I do that without a nursery? And then I went to a couple, and fortunately, the first 4 or 5 I went to were unbelievably beautiful. Had there been trauma or had there been a problem at one of the first 2, I don't know that this all would have turned out the way it would. And so, and it's been the best decision of my professional career. It's freed me up from all the silly rules and algorithms and policies and protocols and stupid meetings and things that go on in a hospital that don't have anything to do with patient care. So it was great. But it was only because I was already a sort of, to be nice, I was probably antagonistic in the first place. I didn't go along with the flow. I was not a sheep.
You're an outlier.
Well, yeah, I guess ultimately I like to think of them as the outliers, but you're right. Because what I do is what nature's always intended us to be doing, and the way it was for hundreds and hundreds of years before this. And yes, we've got modern things, the techniques. I carry a vacuum to a home birth. I carry forceps to a home birth. We carry medicines to the home birth. We carry IVs and things to make the uterus contract and help stop bleeding, and antibiotics and local anesthesia. And I am an outlier, but it's not like we go to a birth with some shoelaces and boiling some water, and that's what we do. I actually think that most people that condemn home birth don't understand about home birth. They don't know what it is we bring to the home. All right, and that's what I went through. The IV stuff, the antibiotics, the things for bleeding, the neonatal resuscitation, the local anesthesia, the suture material, and I bring vacuums, and I have forceps, several different kinds that I have used at a home birth if necessary. And people will say, well, how do you do that without anesthesia? Well, you do it with a good relationship with your client, which is one of the strongest points of the midwifery model of care, is that we get to know our clients. Our prenatal visits are an hour long, and there's continuity of care. There's not the shift mentality of things. And
there's a lot of strong evidence base for that as well. It's probably one of the biggest researched areas in medicine, where relationship-based care in a continuity model absolutely provides better outcomes for the patient or the client, but also for the care provider. There's higher rates of satisfaction for both parties and better outcomes for everybody. And that's been shown in maternity care as well, specifically with the midwifery continuity of care, absolutely providing better outcomes. And wherever there's continuity of care, wherever there's relationship-based care, there's more trust, there's more connection, there's more ability to recognize when that person or the patient or the client is actually needing help and when they're not needing help. And that can only be developed through relationship-based care. And so, a lot of those things that people, like you're saying, what's replacing the epidural? It's the woman's own capacity and to move around, and her trust in you as her care provider to help her when she really does need it. All of these different things. What's replacing the nursery? It's the home. The home replaces the nursery. The warm bed, the family, the love, the care of that family for that baby replaces the nursery. It's not that, like you said, you're not showing up with a shoelace. And I think a lot of people absolutely don't get that at home births, the care provider shows up with all the things that are needed in case of an emergency, in case you do need them.
Right. And again, I do live in a very large metropolitan area. So literally, on the rare cases where we have to call an ambulance, all right, they're usually there in 4 to 10 minutes at the most, and you're not more than about 6 to 10, 15 minutes from a hospital generally. And, it's not like we're doing this up in, out in the bush or deep canyons around here in Southern California. And we're making choices. And when a woman who lives in a deep canyon decides she wants a home birth, and she doesn't want to go to the hospital for whatever reason, she doesn't want to go, all right, then if otherwise things meet the criteria for normal birthing, then it's better for us to be there and help her than to tell her, I'm sorry, you'll have to give birth unassisted.
Absolutely.
Right? For instance, I have an example. I have a woman who yesterday I canceled on you for this set of twins, and she was looking at options, and she didn't have a lot of options. She's down in San Diego. She didn't have a lot of options. I met her like 2 weeks ago because she was sort of realizing that they were going to induce her at the hospital, that they were going to either that or they were going to section her right off because one of her babies was transverse lie, and they weren't going to let her deliver vaginally. And so she started looking for options. And one of the things she had talked about was she thought maybe I would just do this unassisted. But after the babies came out yesterday, and they were head down, and they both came out fine, 34 minutes apart, I think. She bled a lot, and it took all of our skill. We gave her IM Pitocin, we started an IV, we gave her IV Pitocin, we gave her misoprostol, and we had to do a bimanual fundal massage where, I had to keep a hand inside of her and my hand on her fundus for a good 5 to 10 minutes, the whole pressure on it. And we were talking to her the whole time. She knew who we were. And so we were confident. But if she had tried to do this at home, it's very likely that she would have either bled to death or had a terrible outcome for herself. So these are things, she should have done it in the hospital. Yeah, but if the hospitals gave women the choice of come to our institution and we'll leave you completely alone. All right? I mean, even though I think getting in the car and driving to the hospital is disruptive to the labor process, the hospital can't possibly do that. The risk managers and the nursing systems and stuff like that aren't going to let a woman be in the hospital laboring and leave her alone. So by the very nature of the system and the economics of the system, which also forces physicians to do volume practices, no fault of their own, but they don't get paid enough per individual pregnancy woman by insurance or by the state, Medicaid in our country, whatever you guys have in Australia. They don't get paid enough to do the same kind of care that a midwife can do, where she can charge a little bit extra money and take a certain number of clients a month and know that she can make a decent living by doing that, because when you work in a hospital setting, you're limited by what the insurance company or what the government pays you. And in order to meet your overhead, you have to do see a certain number of patients per hour or do a certain number of deliveries per month. And it doesn't allow you to spend an hour with each patient in your office. You can't possibly do that and make a living in the system. So the system, again, it's the third or fourth time I've mentioned it, but if we really want to change maternity care in the Western world, we need to change who runs the system. And ultimately, your last question to me we haven't even gotten to some of them, but your last one is what can I say to make it better? I would tell every woman who's pregnant to consult with a midwife during her pregnancy. Doesn't mean you'll stay with her. Doesn't mean that you'll have a home birth. Some countries there are some countries where you can get a midwife in the hospital setting. That's fine, but at least consult with a midwife. Do some of your prenatal care with a midwife. So even if you have to pay out of pocket to do it, because even if you're in an obstetrical practice, you're not going to get the same attention to detail. You're not going to get the same nutritional instruction and stress reduction and exercise coaching and nipple preparation and home and how to take postpartum preparation and all the things you're not going to get informed consent about diabetes screening or group B strep or vitamin K or the newborn screen. You're just going to be told, these are the things we do. Here at 28 weeks, here's a bottle of stuff, drink it and come on in. We'll draw your blood. You're not going to be told these things. So if you want a better experience, hire a midwife. Even in my country, some people I suggest hire a midwife. If they're going to have a hospital birth, hire a midwife as what's called a monitorist, which is somebody who can come to your house and monitor the baby, monitor your vital signs, and keep you home until you're like 8 or 9 centimeters, so that you don't get to the hospital too early, where this whole medical cascade of interventions can happen. That's the biggest problem, is getting to the hospital too early.
So hire a midwife is great for the person accessing the care. And do you have one little piece of advice to give to I think especially obstetricians, in terms of what can they do to broaden their skill set? What can they do to, should they hire a midwife to teach them? What can obstetricians do?
Well, they could hire physician extenders in their office to do some of the prenatal care, I think, and hiring a midwife or a certified nurse midwife in your office is first of all, it's a great marketing tool. All right, women like that.
Yeah, a lot of women are looking for that relationship.
They're looking for that. So that's one thing. I mean, it's hard for physicians who are out practicing already to go back and get the skills that they haven't gotten. As I said earlier, if I was in training, if I was a 3rd or 4th year medical student, or I was a resident in OBGYN, I would demand from my residency program that they teach me these skills like breech and twin delivery and forceps. And if they won't teach it to you, demand that they pay for you to go to Germany or go to Australia or go someplace else, or go spend a month and a half with Dr. Fishbein in Los Angeles. They won't let them do that because I'm not accredited in that way. I don't have, I'm not affiliated with any school or anything like that. And so there's too many obstacles. It's very difficult. I do have a medical student, I'm thrilled, coming to join me in 2 weeks, and she's going to spend 4 weeks with me in one of her rotations. And I love that. This is the first time I've had a medical student come in 10 years. I've had a medical student be able to come and spend time with me. And the things that she will see will be something like that they'll never see in a hospital setting. Just even the way we do prenatals, where we sit around and we don't have the COVID restrictions where we don't let where they don't let the husbands into the prenatal visit, or the husbands can't come to an ultrasound. Or they can't bring their children because we only have one family in the office at a time.
Amazing.
Yeah, I would like to finish with what else I would tell doctors is to take a step back from all your training and have an open mind and try to look at birth a different way. And even if you're not comfortable yourself practicing that, be comfortable in saying to a patient there's a few famous words that you could say to her when she asks you a question. You could say, I don't know the answer to that. It's okay not to know. But there's some guy over there that knows, or there's some woman, I know there's a colleague of mine and she does that. So why don't you do that? It's the same thing with surgeries. In GYN surgery, there are people that do surgeries all the time. They may be better at it than the office gynecologist. It's not a matter of pride or money. It's a matter of what's best for the client. And so honoring true informed consent and saying to someone, I'm not a fan of that, or I don't know how to do that, but there are people who do. So why don't you go talk to them and then come back and visit with me, and we'll have a conversation about what you learned. And because we know each other, we've known each other for 10 years, but I don't do breech delivery, and your baby's breech, and we can talk about turning your baby or not turning your baby, but give people the options, and don't be so frightened to funnel them, like by skewing your counseling to funnel them down a path that you want them to take, because that's not really ethical.
Absolutely. And I love that. I think that's a really beautiful point in terms of kind of closing this conversation and leaving people with each individual who's part of this system, who's accessing healthcare. From the person who's accessing healthcare point of view, it's your responsibility to engage in your own healthcare. Healthcare improves when you engage in your healthcare, when you're part of the conversation about what's right for you and your body and your baby and your family. And healthcare improves when the clinician, the person providing the care, is engaging with their patient and asking the right questions. And like you say, I think it's imperative that we can say, I'm not sure, I don't know about this, but how about we look into it? Or how about I look into it? Or how about you go to this person over here who does know the answer to these questions, or to this thing that we're facing here. And I really love that we're finishing on that, because with a question, we're finishing with a question, not so much a statement. Go out there and do more research. Go out there and speak to your clients, listen to them, see what it is that's important to them. Even if you don't have time, push that boundary a little bit more and spend a little bit more time, even another 5 minutes with your patient. And I think those are really powerful.
Yeah, one thing I've learned, Annalie, over the years is that how a woman gives birth really matters to her. And it's not something that's taught in residency programs. All right, residency programs are results oriented. They just say, we got a baby in the bassinet. What are you complaining about? We've all heard that sort of thing.
Absolutely. We've got podcast series on that particular thing, that, you know, that exact thing. We've spoken to hundreds, maybe thousands of women and people who've given birth over the last decade, actually, of continuous interviews. And one of the things that stands out the most, we've spoken to women in their 90s, in their 80s, in their 70s. When you speak to them about their first, their second, their third, their 10th childbirth experience, and they'll be in tears. Yeah. They go straight to that place. Trauma is held in the body in a way that many of us don't. We're starting to understand it. It's in our nervous systems. It's in our cellular memory. It's written in our genetic, in our RNA. It's in our being. It's part of who we are. It's part of how we survive on this planet. It helps inform us what to do and how to behave. And when you speak to a woman in her 90s who remembers her 7th birthing experience, and she wished she could have done it differently, she wished she had the support she needed to do it properly, you can't help but think that the whole system has to change. We can't be doing this to families and the way that we're doing it, and we have to ask better questions. We have to.
I can't say it better. Thank you. That's great.
You've been listening to an interview with Dr. Stuart Fishbein. Dr. Stu, you can find out more about his work at birthinginstincts.com. The link will be in the show notes. For more information about pregnancy, birth and beyond, head to pbbmedia.org. I'm Analia Tia. We love hearing from you, our listeners. Drop us a line, hello@pbbmedia.org, and through socials on Instagram at pbb_media and Twitter at pbbmedia.
We hope you've enjoyed this episode of Pregnancy, Birth and Beyond. Tune in next week for more information and inspiration, bringing us full circle. You can find our show on iTunes, Spreaker, the usual social media under Pregnancy, Birth and Beyond, and our website at pbbmedia.org.